Good morning, everyone. Thanks for the introduction. So my name is Luis Marco Ruiz, and first of all, I would like to thank Alvin and your organization for hosting me today. So I always work mostly based on Europe. It's a pleasure to sort of expand the borders of my work and be able to present our perspectives and what we've done so far and what we think and how to approach these kind of projects. So today's topic, as you already mentioned, is the open source health information systems, opportunities and challenges. And I would like to present it from a data management perspective. So not that much from the pure software perspective, but from the data perspective, and I will explain why. Why is that? I will skip the introduction since you already presented me. And in this presentation or webinar, what I would like to answer briefly is this question: what are the advantages in using free open source software from a government perspective? So why should we use it, and what are the advantages? And maybe it's not always possible to adopt it at the stage we are in a particular organization, but why should we keep it in mind, at least for the long term of the organization? In the screen, you find now the agenda we follow. So we'll start introducing the concept of health data as a strategic public asset. To jump in and present what is vendor locking. I will present a specific example I'm originally from Spain, so it's an example from my country, which expresses very well the situation we may be if we don't think strategically about health data. And this will explain why sort of we say data is for life, however software is not, because software changes. In time, it evolves, it becomes obsolete, and we need to change it. But data is not. We need to always keep this the lifespan of the patients and the lifespan of health data stored and available to deliver the best healthcare possible. And then I will talk a little bit about digital health ecosystems and the open platform approach from a free and open source software perspective to implement these digital health ecosystems. And to end with a little bit of the challenges and common fears that there are when adopting these projects. And then I will finalize the presentation with presenting some larger scale projects, which are usually national projects from both Germany and Spain. So, as I said, I'm orientating this presentation from the point of view of health data as a strategic public asset. So we find that, I think this is from around 2000, some of them 2017 to 2019, we found many of these news in remarkable magazines and the newspapers. So we found, for example, that most of the people were speaking and saying that the most valuable resource is not anymore oil, but it is data. They were saying data is the new oil, and that had a lot of impact, for example, in the country I work in, which is Norway, which has a partially oil-based economy. Because in Norway, the Norwegian thinking is, okay, we need to progress to a more value-based economy, not to be based so much on the export of raw materials. And the management of data there is based on, it has some characteristics like a unique patient identifier for everyone, which is stored and available, and there are cross registries connections and so on. So in Norway, we thought that there's a real possibility of actually using this data. However, it's not that easy, and the devil is in the details. And what we found and what we find is that then these promising news have changed a little bit, and now with the same magazines say data is the new oil, but it's not enough, and that is because simple data was nothing, and particularly in healthcare we have tons of data, but this data is low quality. So we need to develop strategies that allow us to use this data, and these strategies need to be need to be led from a high-level perspective, but also account for the low-level needs from clinicians and so on to allow them to store this data in a way that it can be reused without impacting in a negative way their daily operations. So I always say, okay, yeah, perhaps high-quality data is the new oil. Thus, we need to think about it as a strategic asset. And of course, not only from an economic perspective, but also from delivering the best healthcare possible and creating new evidence. So in this regards, we find initiatives like the European Health Data Space, which is trying to somehow be able to index and possibly gather some data among countries. It's not going to be easy because of the privacy legislations and particularly the GDPR regulations and the Digital Europe program, which is sort of the general vision that encompasses all these initiatives. Here I'm explaining a situation we don't want to go into. So when I speak about data as a strategic asset and how free open source software can collaborate to treat it as the strategic asset it is, this is the situation we want to avoid. So this is from a hospital, which is around driving, it's around 1.5 hours from the place where I was born. It's called Torrevieja, and that is the southeast part of Spain. Basically, this belongs to the region in the health region and the health trust in Valencia region in Spain. So there was a sort of mixed model of public-private healthcare. So basically, healthcare is public, but the management of hospitals for some period of time was privatized. So there is a company that operates and manages the hospital, but they receive funding or they are funded with public resources, public funds. However, there was, and this was working like this several years, but there were some problems. So the people was not fully comfortable with this approach, and also there was a change in the politics at the political level. So another party won the regional elections, and then they decided to finish this kind of way of organizing healthcare, and they wanted to take public control of the management of hospitals. Again, so for these hospitals that had this model, they took control back. So they told the company, which was called Rivera Salud, that managed the hospital, that they would not longer prolong the contract and they would take care of the management. Now, what happens is the company said, well, okay, so if you are taking control, this means that you are not paying for me for this transition process. This means that the very day I stop my contract or my contract finishes, I'm not doing anything else. And that's what they did. And it was a scandal because we found in the television, in the regional television, for example, a patient, this is a real case, a patient in the door of the hospital saying, I have cancer and they cannot give me an appointment because the system is down, or they cannot use it because the company owned the electronic health record. And when this happened, the regional government said, well, this is our health region. And according to the law, this hospital and the management belongs to us. So we'll take our IT team there, and they are in our health network, health IT network. And so then we will connect to the database and see if we can at least take some of the data out and start making this work, at least for the basic services like appointments and so on. So that's what they did. They went into the database and they tried to get this information and access there. And the very day they did that, they were sued and they were taken to court by the company that used to own the management and the electronic health record. And that's and then I was called to one of these programs in the television to explain, well, why does this happen if the management is ours? And that is because they are in a situation which is called vendor locking. So this means, yes, you may own the hospital, you may be paying for the services, for example, for running the electronic health record. You may be, according to the GDPR law in Europe and in Spain in this case, what is called the data controller, but you don't have the right to go into the database, explore the database and extract the data because there are intellectual property issues there. So if you didn't account for this aspect contractually when you sign your contract, then you're thrown in a situation which is called vendor locking, as these people. And it was a terrible scandal. And the worst thing is that you could see patients in the television really affected by this, so with treatments delayed and so on. So that's the situation. So basically, here I'm showing a little bit the architecture of what would be a very basic schema of an electronic health record. And we see it is sort of the core in our healthcare system nowadays. that it's a system made of systems with laboratory information system, image systems, a journal, etc. And then there is a sort of domain model that tells us how clinical documents in our electronic application are going to look like. And then that is stored. So this situation of vendor locking means, I'm setting here this lock sign, we cannot directly go here. We need to sort of speak to the vendor and reach an agreement on how we can access this data. And sometimes when there are these problems transitioning from one vendor to another, or there's a change in policy, this may create issues. Now, how can we sort of avoid this situation? In this case, we may think, well, I could potentially, if I'm transiting to a new electronic health record, like it was the case with the Valencian Health Trust and Libera Salud, which was this company, I could potentially try to do this, like exporting data from the database. But you could see in that case that there are legal problems because of intellectual property that are involved there. And you could potentially try to export this, but this is not always possible because you will need the new electronic health record and the old one to agree on some kind of a standard like HL7 Fire opener. And then you of course you would need to rely on this vendor to be able to do the ETL process, extract this data and prepare it in a way that this new electronic health record can understand. And what usually happens is that a legacy electronic health record model cannot be fully migrated into a new model. You actually need to somehow maintain this database with the old information there and somehow enable some visualization, because it's just too difficult to restructure clinical data because of all its complexities and preserving its context, who recorded the data and so on. This might be a too different model to do that and accommodate this original data. So we see we have a problem here when migrating in between systems. But the problem is even bigger when we think in today's healthcare, and we think in artificial intelligence applications that want to use the data that is hosted in the electronic health record, or we think in patient apps for follow up these patients at home, and so on and so forth. So we are speaking now, as I will mention later, about healthcare ecosystems. This is again this possibility of migrating software or enabling access through a standard interface, which could be HL7 Fire. But again, there is a problem here because there is a cost in doing this, and you need to rely on the specific proprietary vendor to translate from his proprietary model into this standard interface. And in many cases, it's not possible to fully structure all this as the standard, because as I said, there are entanglements in between the demographic information with the clinical one and so on that are too difficult to be expressed in a standard way. And this, as I said, we need somehow to enable these systems to work beyond what is the electronic health record. And this also affects not only healthcare, but also small and medium businesses. So we need to be able to allow apps developers, computerized clinical decision support system developers, and artificial intelligence systems developers to plug into our electronic health records and use this data to create new evidence and provide a better healthcare at the end. And so, as you saw, we have a problem with our core platform, which is the electronic health record in this case. And this takes me to this is a famous paper. I will send you the slides. Or I think the organization will make them available. This is inspired by this paper here. And basically, we need to think in which situation we are when we procure this kind of system, like a new electronic health record or a data integration platform and so on. So we need to account for how many organizations are providing this platform. Could be one or could be many. And who controls the platform technology? Is it only one organization or is it many organizations? If we go for one, let's say one organization providing the platform and one organization providing the technology, we are in a situation where there is one vendor. So, and that's not necessarily bad. But in the long term, you need to be aware of this, and contractually, you need to make sure that this strategy is not jeopardizing your data reuse, your secondary use of data for research, transiting to new vendors, access to small and medium enterprises that want to develop more specialized applications on top of the electronic health record, etc. So sometimes a hospital is in a hurry and they need to purchase something that is working in a time span of 6-9 months. So in that situation, yeah, you may consider going for this one-on-one model, where there's one organization providing the platform with the business model already developed there. And let's say that's the easiest way to adopt an electronic health record. We would find another model, which is there are many organizations controlling the technology and one organization providing the platform. In this case, this is from Valencia, but it's a different case of the systems they use in the Valencia region in Spain. So basically, this is the Health Trust, developed together with a company which is called Entity Data nowadays, a joint venture where they develop a shared electronic health record. So they paid for the development and they own the system, but the company also has some freedom to go to other countries and sell the electronic health record. So this would be the joint venture model. So in that particular case, it's not open source, but let's say the health trust is still keeping ownership on the system and the source code. So potentially they could change it if they decide to move to another vendor. And then we have this model licensing. I couldn't find any example in healthcare where we have a licensing. Maybe there are, but I don't know. Where we have many organizations providing the platform and only one controlling the technology. But I found many here. Here we will be, I think, this is the closest to the free open source software perspective, which is many organizations provide the platform or potentially can provide the platform, and many organizations control the technology. So even though it might be only one at this point in time, since it is free open source software, there might be other vendors and organizations stepping in and starting to support this. So from a long-term perspective, I think this is what we are interested in. If we think on this data as a strategic asset, as I was mentioning, we should go for the share model, where many organizations, there are many organizations and many platforms, and many organizations also control the technology to avoid this vendor lock-in that was presented before. So I'm finishing now the first part of the presentation, and this is kind of the message. So data is for life, but software evolves, software is changed, and software becomes obsolete, and we need to substitute it. But data will still be there, and we need to make sure that we will have access to that data, and this data will still be useful to us to do data analytics, to learn from it, epidemiology, surveillance, etc. Even though it might be old data. So I'm jumping into this second part of the presentation to speak about digital health ecosystems. So nowadays we don't think any more about this big monolithic platform of the electronic health record as the only system that operates in a health organization. So with the, let's say, with the use of computerized clinical decision support systems, the needs for epidemiology surveillance that we can observe nowadays with the current SARS-CoV-2 pandemic, there's also a need for health quality measurements, development, etc. We need to think in our applications as a sort of common bag of different applications that interact among themselves in a symbiotic manner, so what is called a digital health ecosystem. And here there's a bit more formal definition, and I will set the reference there. But in essence, these digital health ecosystems contain many independent but autonomous technologies and applications. There's a high diversity of vendors that need to collaborate and help each other. And when I say vendors, also not only vendors, but organizations, different healthcare organizations, and also, for example, social care services and so on. They need to collaborate to provide the best healthcare possible. And there's a low coupling in these applications, but still they need to be able to interact and share data. So why do we need these digital health ecosystems, and how do we enable them in the sense that applications can share data and behave in a symbiotic manner? Well, we need the rationale is that end users nowadays are not really part of the digital systems they use. So what has happened so far is that a clinician is given a particular electronic health record and is said it's told to use it when he or she works in a specific hospital. But it's very difficult for them to influence a big vendor. And in this particular case, for example, we are speaking about really large companies that are settled overseas. So this clinician that is sitting in his office visiting patients cannot influence, or it's very difficult for him to influence this development of new features. He might influence some local adaptations, but not the addition of key functionality for the future, like artificial intelligence or whatever. There's also a big problem when it comes to, it actually affects the economy of the countries in the healthcare IT domain, which is that small companies cannot enter the sector because there is an oversaturation. And that is reported in a paper from Colicchio and Semina. And we don't want that to happen, particularly in small countries like, for example, Norway, where we would like to develop a new businesses and transit to a more value-based economy. And some authors also advocate for enabling platform ecosystems. That's what I'm talking about. So we need to make different systems to interact in a symbiotic manner while still being loosely coupled and being not too dependent. And there's an advantage in moving towards this open platform model and digital ecosystem model if we manage to include small businesses, since it's easier for clinicians to influence these small local vendors who can create more specialized functionality on top of the electronic health record than influencing a large corporation. So there is, in general, there's a desire to move away from the idea of a single main supplier to an ecosystem of products with different vendors, different small and medium enterprises providing healthcare and collaborating with the different health trusts. So how do we do that? Well, that should be done from the open platform perspective to enable this ecosystem. And according to AeHIN, this open platform perspective needs to guarantee the following. There shouldn't be restrictions placed on the participation in the development, commercialization, and use. And also, any restrictions set on the implementation, compliant with the standards and so on, shouldn't be discriminatory. So basically, what this is allowing is to extend the functionality of in this case, the electronic health record, for example, with more specialized functionality potentially provided by other vendors without discriminating these vendors. So we need to enable the process where they can access this big platform without alienating them because they're not part of the organization or the vendor corporation. So this I already mentioned, so I will not go into the details. So basically, we need to think in the cost of providing this. So we may try to enable this digital ecosystem and say, well, we will adopt standards for interoperability. And in Europe, we have spent billions trying to develop the perfect standard and the perfect solution, and we are still not there. So it's not working. We are able to share the patient summaries, but the healthcare domain is so complex, and the dependencies on data when we go to the persistence of it and the entanglements with demographic data and so on make this translation from proprietary to standard very complex and costly also. And also, if we go to this particular model, sometimes I may need to extend the functionality of the core platform, which is in this case the electronic health record, for example, for supporting more omics information in the sense of genomics or bioinformatics or whatever. And I might not be able to do it if there's a proprietary model that contractually is stopping me from doing that. And what I need to actually change the way this data is modeled and persist in the main core platform. So that's where free and open source software provides a solution. here I'm clarifying something. So free and even though when we speak about open source in general, we mean free and open source software, it's not necessarily like that. So there might be, and this is again, the devil is in the details. We need to make sure when we work with open source that we are using free and open source software, or at least that this open source licensing schema it does not have any hidden details that are going to jeopardize my data management strategy in the future. And that is because sometimes some open source projects, they allow you to access and study the code. But when it comes to the executables, you cannot really use them as you wish, or you cannot extend them, etc. And also sometimes we find that some in the healthcare domain, there are some applications like terminology services that provide an open source schema. But when you go into the detail and you run a test over them with real data, we find that it's not really possible to use them without the vendor, the original vendor. So it's like there's a kind of a facade of open source, and they are somehow open source. Yes, you can download the code, but there is, for example, a key configuration data set that the vendor has to sell you, in order to make the system work. Without it, you can basically not make it work. So we need to ensure that our licensing schema allows us to do all we can do or all we want to do in the future to treat data as a strategic asset. So this is why I'm saying we need to ensure that and study the differences between an open source and pure free open source software. So when we speak about free and open source software, there are basically four essential freedoms. The first one is that you should be able to run the program as you wish for any purpose. Maybe testing, maybe doing new developments, etc. Maybe in the operational domain, and so on. The second one is that you should have the freedom to study the program and how it works and change it. So it does your computing as you wish. That's the second freedom. And you should also be able to redistribute copies so you can help others with your development. So if I'm working with this schema and I make a development, for example, for a module in an electronic health record that is supporting some new functionality, I should be able to, or the licensing schema should allow me to share my new developments and sort of enrich the community of users of that particular software. And there should be a freedom to distribute copies of this modified version to others. So when we say free, it's important to understand that it's not free in the sense of it will not cost me money. It's free with respect to these four basic freedoms we were talking about: to run it, to study it, and change it and redistribute copies, with or without changes. But of course, we will run into a cost of getting support for this, maybe customizing it, etc. And then I would like to present what I call the common fears. Some of them I think are already reflected in the work of Alvin Marcelo. So we find that some of the common fears are the lack of widely available support and maintenance. And yes, that is a risk, but that is also a risk when we purchase a vended product. So sometimes this vended product is from a corporation that is overseas, as I said. And this takes me to the need of developing a local expertise. So no matter if we purchase a vended product or an open source one, at the end, the complexity in the healthcare domain for one particular organization is so specific that we see that we will always need to train our own experts to become to be able to use it and deploy it and maintain it locally. So I don't see a reason for this fear, because the risk of this is also present in vended products. There's also a difficult to recruit experts, and that is true. Yeah, if we think, for example, in a vended product, in the contract, you may have some consultancy work and some amount of hours when it comes to getting maintenance for your vended system. Whereas in open source, sometimes you may find it, sometimes it might be more difficult to find this. But then again, you can of course do it at the procurement stage and establish that into your procurement. So for example, if we think in very extended free and open source software products, like some versions of Linux, there are companies that provide worldwide support for that. And then again, I think we will need to, at the end, develop a core team of experts that are able um, to learn from this and become experts and to be able to deliver value to our health organizations. This is probably the most reasonable fear, which is a complex cost estimation. When you purchase a vendor product, you procure a vendor product, it's very clear what is included, what is not, how much is this going to cost me, and you have a range of prices, which for me at least is a bit more blurry when it comes to free open source software, since I may need to go to several places to get the full overview. Okay, how I will need a vendor for providing technical support. I may need a specific internal team for checking and establishing the requirements and so on, and then take them to the developer of this if it is another external vendor and so on. So it's more complex to get the full overview. When it comes to security concerns, I don't think that is actually reasonable, because both in vendor products we may have vulnerabilities. If the product, for example, is developed in Java, and we are having this recent vulnerability from 2021, like for example the log4j vulnerability. At least if it is a free open source software, I can check which version of the library they are using and know and make a list of the possible vulnerabilities. If it is a compiled product, I may not be able to access that information. So for me, that's not a reasonable fear. And there's another one, which is lack of understanding on who controls the software. This is, I think, I can be mitigated with some training on the procurement, let's say, phase or organization. Require customization, we will always have this problem. It doesn't matter if it's a vendor product or it is a free and open source software. Because if you go, for example, to a big vendor product from one of the American corporations, Cerner, Epic, and so on, they require customization for each new case. So of course, that customization may be more scalable when it is a very well-established product, but we will always need it. And the lack of maturity, high risk. I think this has to be evaluated, of course. There might be a free open source software available there that is not mature. So we need to make sure that this is mature and it's supported and so on. But this, again, is something that needs to happen at the procurement stage. So some of the advantages I see when relying on free open source software are that it allows for different technologies to be tested and evaluated. So we can potentially give the freedom to health trusts to use one specific free open source software system or several, and then evaluate which ones succeeded in their objectives, which ones did not, and to which ones we should allocate more funding, and which ones should we stop funding and then concentrate in those that were successful. So this is going to allow us to have a better understanding on which technologies are better suited for our proposals, minimizing risks at the high level. And as I said, it's going to give small vendors the possibility to develop specialized products in our local market. So we are having a positive impact also in our country economy, particularly if we are small countries who do not usually own one of these big corporations. So we can also, expertise can be built locally, and we will help with this schema to build a network of small businesses that eventually may become stronger and may start selling outside our country, again, benefiting our economy. And there are some examples for this I will give you later on. At the end, what we are doing, if we make a proper strategy, is we are working more evidence-based. So there is, I think there is a great need, and we are not there yet. There's no magic recipe for that, but there's a great need of working in an evidence-based manner when it comes to medical informatics interventions with more transparency and free competition. And here I'm giving you some key points to consider when we are speaking about using both free open source software and the open platform ecosystem, which is we need to treat data as a strategic asset. So we can do that by relying on free open source software, or at least developing these APIs and develop contracts very carefully at the procurement stage so as not to run in this vendor locking. And we need to think 10 and 20 years ahead strategically what is going to happen with my data if I purchase a specific product. We need methods for measuring success, so key performance indicators that allow me to observe these sort of interventions or these investments. So it's very likely that I will do several investments and some of them will not work. And this has happened in Europe many times over the last 20 years. So we need to strategically develop in the first place some ways of observing their performance with some KPIs. We need to establish a framework that allows maximum collaboration between both health organizations and small vendors. But we should minimize our intrusion. So we need to let these health trusts, clinical professionals to interact with these small vendors to develop their products. And users, researchers, and health trusts need to be listened when it comes to the development of these ecosystems. And we need to sort of think, as I said, strategically in the long-term evolution and be time flexible on the health value provided. And allow mixed approaches. Sometimes what we see, for example, in Europe is that there has been a lot of main projects, national projects that take only one direction. Sometimes it's better to split this investment and leave some parallel tracks to be able to observe what works and what doesn't. And it may look like a replication of investment, but it's not like that because the healthcare domain has demonstrated to be so complex, and there are so many examples of failures in Europe, for example, that it's clear that we need to change our approach to this, to a more bottom-up approach, where we let more local freedom to do some of these IT investments. And as I said, we need to ensure data ownership and control stay in the public sector in this case, and we think strategically about data and its scalability for the future. Especially if we are not using free open source software, because we need to be very careful of our contractual conditions. So we need always to think about data reuse and leverage it with usability from the health professionals' perspective. And now this is the last part of the presentation. So it's just some real examples. This is in Norway, there's been a debate over the last 2-3 years about a system called AeHIN. So AeHIN was meant to be a system, or is meant to be a system, that will provide an electronic health record for primary healthcare professionals, mostly for GPs and nurses. And at the beginning, the strategy was developed from a top-down perspective. So the Directorate of Health, which is an office inside the Ministry of Health, developed with goodwill, because they know the needs, develop a strategy to sort of establish one specific platform and maybe enable its interoperability towards some interfaces. But the specific, the big platform, let's say, will be most likely purchased or built with a more proprietary schema. And it would be one instance having all the data and putting all the data together. And there was a reason for that, and it's that the Norwegian market, when it comes to primary care, is it's very scattered, in the sense that each GP office has freedom and each municipality has freedom to buy the electronic health record they like or they prefer. So we have many systems, many difference among them, and it's very difficult to develop a strategy for data reuse, for doing clinical research and so on, for using daily operations data. However, when this was proposed, there were many voices rising against that strategy from both researchers and even medical associations, which stepped out from the project because they said it's not possible that you put everything in one place and you expect this to work with a big platform, even if you give the interfaces, because at the end we need something more flexible. We have many municipalities and we have small businesses and small needs, each of us, and we need a system that really guarantees us this level of scalability, flexibility, and be able to give the opportunity to other vendors to develop their stuff. So there was eventually a movement from this main frame perspective to a more like open platform ecosystem where different systems can collaborate and behave in a symbiotic manner. I will not say this is solved because, of course, it's more difficult to create a strategy for developing one of these open source ecosystems, digital ecosystems, than purchasing one platform. So there's still an ongoing discussion, but things are moving towards the direction of enabling this kind of ecosystem and working more from a bottom-up perspective than from an imposed big platform, big platform which is purchased and everyone needs to use. This is a project, this is an example on how we use some funding in a project to develop an open source software, a free open source software. This is AeHIN, and this is an example from Germany, where they split funding for medical informatics initiatives to observe how they behave. So in 2015, the federal government decided that they were kind of lagging behind other countries when it comes to medical informatics research, and particularly when it came to data reuse for using electronic health record data for running clinical studies. So they launched 4 initiatives, very well funded, so around between 30 and 40 million each euros. They were in parallel, so they were supposed to collaborate but also compete, and give them 4 years to observe how different technologies were behaving. So these initiatives started working. I was working with one of them, which was called AeHIN, for 3 years. And this is a bit the sort of infrastructure. So many of this was done in a sort of open source way. So some of the software we had to buy, for example, in the case of the Opener database, Opener is an open standard, but it's not open source. So we had to purchase one database. And we used some of the funding, we were allowed to use it to start to pick up one prototypical open source database that was out there from the UK and take it in Germany in the consortium and start building it so it would become more robust, usable, and trustworthy. So that's what we did. So the initial stages, thanks to these open, let's say, open standard APIs, we were using the vendor product, and but we also developed a new platform, which is an electronic health record database, which would be free open source. So and as a consequence of this initiative, and because we had developed that, it came the pandemic in the meantime, and we were asked by the federal government, okay, so you seem in a good position to collaborate with other or lead the medical informatics initiatives towards creating a data warehouse for research in COVID. So thanks to this development, we could propose to use our open source database, and now it entered into production for storing COVID-related information about patients and so on. And not only that, but we open sourced also Fire Bridge that would translate between different standards of Fire, in this case, and Opener, which is the one in the database, and also a company open sourced an access based control mechanism for data. So each clinician doing research would access only the parts of the data set that he or she is allowed to, depending on which research study he or she belongs to. And then we also collaborated with another initiative, which is also free open source code, which is the Proscribe, which is a software for ethical approval, where clinicians could vote online and get the ethical approval and put it automatically into the system. So thanks to this previous investment, we were able to develop a full framework with mostly based on free and open source software that could do COVID research at a national level in Germany. And you can actually access the code and use it in the way you want to. It's here. And I think this is mostly it. So I would like to keep some 10 minutes for questions. So I've tried to answer this question I presented at the very beginning. So what are the advantages in free and open source software from a government perspective? And I think it's mostly, in my humble opinion, I believe it's the best way to treat health data as a real strategic public asset that can both improve healthcare, benefit patients, and improve also our economies, helping our small and medium enterprises. This is it. Thank you very much.
Thank you very much for the presentation, Dr. Luis. This is actually a high yield webinar. We have 38 people in the room right now. So to go through the questions, our first question is from Dr. Alvin. So what resources or capabilities must be present in governments so they can properly govern or manage FOSS applications?
Okay. I think it's not a question. It's easy to answer, but I'm going now to this the common fears slide. So I think we need people or professionals who are able to understand very well the licensing schemas for controlling the software, and also to select support for the software and develop a long-term plan. And yeah, and do the cost estimation. So I think we need professionals inside the ministry who understand these 3 points. So support and maintenance, understanding the licensing schema and who controls the software, and be able to do this complex cost estimation. The other fears, I think, they're not that reasonable. It's mostly these 3 that we need professionals that are versed in these topics to be able to adopt a free open source software.
Thank you, Doctor. Our next question is, what can be considered as the common hidden costs of FOSS adoption? Any advice on how to resolve these?
Yeah. Okay. So yeah, I will use an example. After the development of this hybrid and these NUM core databases for COVID research, we developed this Air-based open source software. And then one day I got a call from a guy who's actually in Spain, in the region of Catalonia, because they wanted to develop their own electronic health record for GPs. And what he told me, we are tired of paying licenses. We spend millions and millions and millions just in licenses, not even in support. So we want to build our own system, and we want to use this open source system. And we were discussing what would be the hidden costs. And I think in this particular case, what I told him, well, you are in primary care, which makes things easier because the models are not that complex, but one of them is going to be data modeling. So if you are thinking in adopting one of these models for a particular hospital, adopting it in a way that it supports the internal operations is going to be complex. It is complex also for vendor products, but when you purchase a vendor product, you usually just accommodate your way of working to the vendor product and not the other way around. Whereas here, you may be seeking for more flexibility. So there will be a cost in doing all the modeling of the different pathways inside the hospital and processes, and the data models, you need to accommodate them. And for that, you need to have both clinical experts willing to step into understanding very well how the system works to define these workflows. But then you are going to need a sort of basic network of small and medium enterprises, which these people have because they are in Barcelona, and there are a lot of small businesses, IT businesses there, and startups. But you're going to need these startups willing to take this product, study it, and start evolving it into what you want. So I would say these are the common costs. So it would take you some time to organize this constellation of different actors that allow you to do such a development.
Thank you, Doctor. We have another question. If an SME offers services to implement FOSS software and are unable to address government's needs, what can the government do?
Yeah, okay, so this is the, yeah, so I'm going here probably to the slide or well, no, I will leave this slide and then I will go to the case of AeHIN. So in Europe, we found this situation many times. So this is going to happen. There's no way you can escape that situation. At some point, you will have some of the developments where they will not deliver. Maybe in most cases, not because this specific SME, and that does not necessarily to be an SME, it could be a big corporation. There are examples of big corporations not delivering. It will happen because of the complexity of the domain. So the way to minimize it, I would say, is, or what we are proposing in Norway is, if you think strategically, not in 4 years ahead, because you are thinking in the next elections from a political point of view, but in 10, 20 years ahead, split funding to parallel initiatives and grant them freedom in the way the Germans did, for example, with the medical informatics initiatives. Split this funding and observe them and learn what is working for them and what is not. Because what works, for example, in the United States does not necessarily need to work, in this case, in Europe or Norway in particular, because the healthcare system is different. So you need to build your own evidence. So if I move, for example, a free open source software that is used in Germany or in Norway to, for example, the Philippines, in this case, it may have worked for us, but it may not work for you if you don't have the right constellation. So I don't think there is a way we can escape from this. We just need to be prepared for this in the sense of trying to parallelize developments and be able to build our own evidence. So we need a strategic thinking for that in the sense of developing our own constellation of experts, including both SMEs, um, health trust experts, clinical experts, and so on. So it's not something we are going to avoid. If they don't deliver, well, they are not complying with the contract and they should be, of course, taken out. But this is why we should, but this domain is so complex, we shouldn't bet everything to one particular initiative.
Thank you, Dr. Luis. We actually have a lot more questions. Our next question is, how can government know if a FOSS provider is eligible or viable to receive a contract for FOSS implementation? Is there a standard contract we can see with the important elements to ask from a FOSS
Mm.
vendor?
Yeah. Okay. So that is very difficult to answer. Yeah. But what we did, for example, in Heimat in Germany, we wanted to purchase a terminology service, and I was the one doing the sort of assessment. So I didn't do the contract, but I can tell you how we did it. So we didn't have any specific template for that. And that wasn't even open source software, but we included open source software there, both vended and open source. And what we did is to sit down with our requirements and define a full set of tests with different dimensions. One was usability and human factors. The other one was uh, ability to perform, for example, phenotyping queries. And another one was compliance with existing standards and so on. And we actually implemented the tests technically. So what I'm trying to say is we did it in an evidence-based manner. So you need basically to test them. So we developed these tests, and then we were filtering in a first stage which of them we knew or could demonstrate that had some running products. They were not only prototypes, but they have been running, for example, in real environments. So we chose, for example, I'm speaking about the terminology service, Apelon in the United States, Onto Server from Australia, Art Decor, which is a European initiative in Austria, and an open source one, which was from Health Intersections. And then we ran our set of tests again against all of them, and then we ranked them. So at the end, what we had is at least we have some evidence that we did our best to select the best option and make the best out of the invested money, because we know there's always in these initiatives a high risk of failure. So we basically work evidence-based and develop your own tests. This is why you need your own experts and build your expertise, because they will tell you what is the best way to make this kind of assessment. So we did this summarizing 2 stages. One was filtering by maturity, and the second one was doing actual objective testing of the software.
In FOSS, if there is a data breach, who takes responsibility and liability?
In liability, okay, yeah. I guess it depends on the contract. At least in Norway, when there is a data breach, what you are forced to do legally is to make it public. So there's usually, if you've done your work well, there is an real serious consequences, in the sense that what they want is to people to be open, because otherwise we will not know how many breaches there are. So from that particular case, we have the obligation to make it public. When it comes to liability, I guess it depends who owns the software and who is providing the service and what the contract says. So data breaches are occurring every day. Most likely we will not be able to escape them. When it comes to the liability, probably will fall on the side of those that are running the system on the network. And it's not always, it's very difficult to assess whose fault it is, because it might be a problem in the software, or it might be a problem in the network. And the software may be provided by and maintained by a third party, and the network is maintained, for example, by a health trust, a branch of the health trust. So depending on who the data breach affects, whether it is a software or not, there might be liability for vendor only or for vendor and health trust or public entity. Not easy to answer. I don't know if I answered more or less.
Thank you, Dr. Luis. Actually, we still have more questions, but we already reached the top of the hour. Would it work for our participants and you, Dr. Luis, if we can also try answering the questions maybe via email or
Yeah.
in our next session? I think
Yeah.
they can still attend if we invite.
Yes. Yeah, I think we could allocate some time, and it's very interesting. And it's also a good opportunity for me to learn from you. So to allocate some time and then answer these questions. Yeah.
Yes, thank you, Doctor. I think we can do that in the next session in May 13. I hope our attendees can join us again on that date. We'll also be sending a reminder to everyone. Before we end, Dr. Luis, we also have our AeHIN leaders on the call. We have Sir Jai Ganesh and Dr. Alvin Marcelo. Maybe they have something to say.
Just to thank Luis and the audience. I think this is a very good topic. Thank you, Luis, for sharing your experience with us, and also to the audience for sharing your wisdom to us. Thank you. See you in the next session.
Thank you.
Thank you.
Thank you. See you. Bye.
Thanks, Luis. This is Jay. Glad to see Margun's article. She was an inspiration about 20 years back. So nice to see her article being projected. And then one of the comments that I had is like, and an experience too, is those implementing FOSS should not ideally be dependent only on the community or external support. I think they should have some institutional or in-house support to manage. That's my experience. Thank you.
Yeah. As I said, it's important to develop your own sort of expertise and build your own evidence with your own experts and tenure. It's not something you can simply go and purchase and expect it to work, because of the complexity of the healthcare domain. Definitely.
Yes, thank you, Doctor. Thank you, everyone, for joining us, and we hope to see you again next month, May 13 at 3 p.m. Manila time. Thank you, Dr.
Okay.
Luis.
See you. Bye-bye. See you.